Good afternoon, OR Today. Thank you all for participating in today's webinar. Remember, you can see the same caliber of education at our upcoming OR Today live conference, August 30th through September 1st in Las Vegas. You can learn more about this surgical conference by visiting www.ortodaylive.com. A few notes before we begin. Attendees were emailed a webinar workbook earlier today. If you did not receive a copy, you can download one now by visiting ortoday.com/webinars and clicking on today's event. During today's webinar, all lines will be muted, but you can submit questions during the presentation by using the questions feature on the dashboard on the right-hand side of your screen. If you're having any difficulty, please email us at webinar@mdpublishing.com. You can obtain a certificate of attendance for your participation by completing the post-webinar survey at the conclusion of today's webinar. The survey will appear immediately on your computer screen, and if you do not receive the survey, please email us at webinar@mdpublishing.com. OR Today would like to thank our sponsor, Pacira Pharmaceuticals. Pacira Pharmaceuticals is a specialty pharmaceutical company focused on the clinical and commercial development of new products that meet the needs of acute care practitioners and their patients. Visit www.pacira.com for more information. Our presenter today is John Malara. John is the Advanced Practice Chief for 3B Orthopaedics and serves as an expert speaker for Pacira Pharmaceuticals. He obtained a bachelor's degree in Rehabilitation Science from the University of Pittsburgh and a master's degree as a physician's assistant from Drexel University. John, you may begin whenever you are ready.
Thank you very much. I want to thank you all for taking the time out of your busy day to attend this WebEx focusing on innovative techniques to improve post-surgical pain management, most specifically related to liposomal bupivacaine or Exparel. I wanted to give everyone a quick background on the practice and physician chair that I work for now approaching 9 years. I started out in the OR as a physician assistant doing a lot of office and clinical work, and now primarily I'll do some spotty time in the operating room with the physicians, but specifically I manage the post-operative patients, both medically and orthopedically on the floor. I manage a team of approximately 12 physician assistants, so we're able to better quantify the pain management aspects and multimodal approach that I'll speak of moving forward. As was alluded to prior, the practice is named 3B Orthopaedics. It's located just outside the Philadelphia area. It's essentially comprised of 18 physicians, and Dr. Booth in particular, who I work most closely alongside with, is a pioneer in this field and has performed more total knee replacement surgeries in the United States over the past 15 years. As a result of his dedication and devotion, we continually strive to innovate and develop new and improved surgical advancements designed to improve the lives of our patients, specifically associated with pain management. Recently, our practice moved from the University of Penn to ARIA Health after 20 years of prior business. As a result of this transition, we were able to closely review our present protocols as they related to post-operative pain management and the multimodal pathway to stay on the cutting edge of total joint replacement. We had the opportunity to visit other high-volume practices to include the Cleveland Clinic and set forth a plan to decrease narcotic use in our post-operative population with the implementation of Exparel, a change that was monumental for many reasons for our practice and most importantly our patients. At this point, I would like to present the slide deck at hand, followed by an open forum for discussion and question and answer. Please feel free to stop me at any time during the presentation for questions that you may have. Does anyone have any questions at this time before I proceed with the PowerPoint?
No questions at this time,
Good.
John.
Sounds good. We'll proceed. Thank you. So the speaker, myself, has a consulting relationship with Pacira Pharmaceuticals, and this program is sponsored and approved by Pacira. As we're all aware, the government as well as the physician population, there's been a strong push to do away with narcotics, what have you, for post-operative pain management. That being said, the focus now is on a multimodal pathway. And as a result of this multimodal pathway, Exparel has made a lot of headway given its non-opioid ingredients, so to speak. So Exparel is indicated for a single-dose infiltration into the surgical incisional area. And along with the Exparel, There's a lot of other different multimodal pathways that we are attacking, again, to decrease the use of narcotics. One in particular that we've also introduced into our protocols is acetaminophen, as you can see. And that the IV acetaminophen or ofuramev has effects on the CNS. There's also local anesthetics, that being the bupivacaine. And again, it's just a combination of a multimodal pathway. And just to give everyone an idea, we went from an experience where we were giving our total joint replacement patients combinations of epidurals, PCAs, loading them with breakthrough IV narcotics as well as oral narcotics. And we can speak on the following as we proceed, but we've seen a lot of decreased adverse events giving the decreased utilization of the narcotics. So that's been beneficial for us. The role of local anesthetics, the idea is to decrease the rate of depolarization and repolarization of excitable membranes. In particular, our nociceptors, which are the pain receptors that send impulses to the brain. There's a lot of different ways that we can use these local anesthetics. Some are through surgical site infiltration, such as our single joint injections of, in particular, Marcaine, catheters, such as you may have heard on Q pain pumps, peripheral nerve blocks, single injections, catheters, as well as epidurals. The use of local analgesics for post-surgical pain, we want to attack the pain at its source, and that's why we offer this direct surgical site or joint injection with the Exparel. Post-surgical pain is mostly nociceptive pain caused by stimulation of peripheral receptors responding to the surgical insult. This is the most effective means of analgesia in the variety of surgical procedures. And again, Exparel is not typically associated with severe side effects or local toxicity, wound infection, or wound healing. When delivered in single doses, the duration of traditional local anesthetics can be the limiting factor, which sets Exparel apart from its competitors. Exparel is indicated for single-dose administration to the surgical site to produce post-surgical analgesia. It does provide long-acting pain control with a reduced reliance on opioids. In fact, approximately 30% reduction in cumulative pain scores were noted in 2 pivotal trials, and a 45% reduction in opioid consumption. There is no need for indwelling catheters or pumps. The clinical benefit of the attendant decrease in opioid consumption was not demonstrated. Exparel is, however, contraindicated in obstetrical paracervical block anesthesia. The most common side effects of Exparel were simply just nausea, vomiting, constipation. The technology behind the Exparel is what's called depo-foam. And depo-foam is a multivesicular liposomal product delivery technology that encapsulates the medication and drug without altering their molecule structure, and basically releases the product over a desired period of time, producing the longer-acting pain relief, basically. And we'll talk a little bit about that. So basically, the medication or this depo-foam molecule is broken down through normal degradation and just the rechanneling of these lipid molecules over a period of time. The pharmacokinetics that demonstrate plasma levels of the bupivacaine that can persist up to 96 hours, and again, this is the slow release of the medication. You can see that there is an initial peak over the first approximately 2 hours, and that's just the release of the free liposomes. About 12 to 48 hours, we really see a peak, in particular to 24 to 48 hours of plasma concentration levels. And you can see it does persist out for approximately 96 hours. Other formulations of the bupivacaine should not be administered within 96 hours following the administration of the Exparel. Systemic plasma levels of bupivacaine following administration of Exparel are not correlated with local efficacy. The rate of systemic absorption of bupivacaine is dependent upon the total dose of the drug administered, the route of administration, and vascularity of the administration site. Blood plasma level for central nervous system effects is 2,000 nanograms per milliliter. And basically, you're looking at the anxiety, lethargy, restlessness, incoherent speech, which can occur with all local anesthetics. And for cardiac effects, it is 4,000 nanograms, and basically that's affecting the AV node or conduction pathway. For FDA approval, as I did allude to earlier, there was 2 phase 3 pivotal trials, one soft tissue and one orthopedic model that both produced efficacy and safety benefits. The safety of Exparel, however, was demonstrated in a larger population in 10 randomized double-blind local administration studies into the surgical site. And they were the hemorrhoidectomies, the bunionectomies, inguinal hernia repairs, breast augmentation, and total knee arthroplasties. Safety, however, was expanded further in 21 clinical trials. 1,307 patients did receive Exparel, 10 wound infiltration studies of 823 patients with various surgical procedures, and it is expanding as we speak. The doses did range from as little as 56 milligrams to as high as 532 milligrams. Again, the most common side effects, which was slightly greater than 10%, were nausea, vomiting, and constipation. There was no cardiac adverse events associated with this or any chondrolysis of the bone or soft tissue. There was no dosing adjustments for hepatic impairment or abnormal findings associated with proper wound healing. Clinical experience to date with the Exparel. The safety and efficacy of the Exparel have only been demonstrated in bunionectomy and hemorrhoidectomy. They were the 2 phase 3 pivotal trials. However, the Exparel has been used in more than 1 million patients since its launch in 2012. Again, the indications are expanding. Soft tissue, bariatric, rectal, ventral, and inguinal hernia orifices, open and laparoscopic colorectal procedures, ileostomy reversals, cosmetic plastic surgeries. The TAP procedure in particular for the anesthesiologist is been being utilized a lot. Specifically in my field from an orthopedic standpoint, we use a lot for the total knee and total hip replacements, laminectomies, thoracotomies being utilized as well. So the dosing of Exparel is available in 266 milligrams, that is 20 milliliter single-use volumes. The recommended dose of the Exparel is based on the surgical site and the volume required to cover the area, and we'll talk about expansion of the volume and so forth to accommodate larger surface areas or larger procedures in particular. It is not weight-based. The dose of the Exparel, however, should not exceed 120 milliliter vial. The key with the Exparel, and this is kind of the most crucial point, it is a very meticulous infiltration technique. It's basically surgeon dependent. It should be injected slowly into the soft tissues of the surgical site with frequent aspiration with any injection to check for blood and blood return and to minimize the risk of intravascular injection. It is recommended that we administer with a 25 gauge needle or larger. Ideally, we like to use approximately a 22 gauge needle to a 25 gauge needle. The smaller the gauge, the more improved results we do see, because that allows for a greater surface area to be achieved, as well as injecting a small amount of volume in multiple different locations, because the goal is to spread these liposomes in several areas of the surgical site. And because of the technology of the Depafoam, there is a need to provide multiple injection areas, because the Exparel does not diffuse as, say, the plain bupivacaine or Marcaine. It doesn't diffuse across tissue as well because of the encapsulation of the molecule. Following withdrawal of the Exparel, It can be stored at room temperature for up to 4 hours, so that should cover most surgical procedures. As I spoke a little bit earlier about the expansion of the volume, this is key to seeing the benefits with the Exparel. When we began using this medication early on, it took us a little bit of time until we were able to provide our patients with the pain relief that we wanted to achieve. And basically, it was a wrong needle size that we were choosing, a technique that we were a little bit unfamiliar with, and it took a little bit more time than we were used to. Dr. Booth and the team, we do a lot of high-volume orthopedic total knee, total hip replacements, and we had to take a step back because we wanted to provide pain relief to the patients, and we had to take a few more minutes in the operating room, and that's where the physician assistants or RNFAs really stepped up and became kind of masters in the infiltration technique. So the Exparel is 20 milliliters. It's a single-dose vial, and in particular for a single knee, we expand the volume up to 120 cc's, meaning we have two 60 cc syringes, and we basically divide 10 cc's of the Exparel with 50 cc's of saline in one of the vials. And in the second vial, we do the same thing, and we inject it at 2 different times during the procedure, and I'll speak to that following the presentation. But the Exparel can be expanded up to a volume of 300 mLs with either a normal saline or lactated ringer solution. And again, the more expansion, when we talk to surgeons that are seeing the results, but they feel as though they should be awarded with more results given their technique, we always recommend expanding the volume because that's what we've seen during our practice and our trials to provide the best relief for our patients. Exparel does not diffuse across the soft tissues in the same manner as bupivacaine. It only diffuses approximately 35% when compared to the plain Exparel. And again, it is a meticulous infiltration technique to ensure the best results. You want to cover a large surface area with multiple injection areas, approximately 1 to 2 cc's. So it can be a little time consuming, but you do want to be meticulous. Some precautions associated with the medication. It is suggested that you wait 20 minutes after administering the lidocaine or other non-bupivacaine-based local anesthetics before administering the Exparel into the same surgical site. It's also suggested to allow topical antiseptics to dry before administering Exparel into the same surgical site. When using the bupivacaine before Exparel, the dose of bupivacaine should be less than 50% of the dose of Exparel. And as a reference, 1 vial of Exparel contains 266 milligrams of free-base bupivacaine. 266 milligrams of free-base bupivacaine is equivalent to 300 milligrams of bupivacaine, HCl. And I'll get into this about what works best for us. I'll get into our protocols and how we use the medication. But 1 30 milliliter vial of 0.5% bupivacaine contains 150 milligrams of bupivacaine HCl. Toxic effects of these drugs are additive, and their administration should be used with caution, including monitoring for neurologic and cardiovascular-related effects to toxicity. There is no significant interactions with the following materials to include stainless steel, titanium, and propylene or silicone, specifically for orthopedic and plastic surgeries. Liposomal bupivacaine should not be admixed with other compounds. They have not, in vivo studies did not show any release of the liposomal formulations that included the NSAIDs, opioids, epinephrine, and tranexamic acids or amicars that are now used specifically in the orthopedic realm to decrease blood loss, as well as corticosteroids or antibiotics. As with all the local anesthetics, monitoring for cardiovascular and neurological status as well as vital signs should be performed during and after the injection of Exparel. And the incidence of adverse neurologic Reactions associated with the use of local anesthetics may be related to the total dose of the local anesthetic administered and are dependent upon the particular drug used, the route of administration, and the physical status of the patient. The one dose of Exparel provides significant pain control with reduced opioid consumption. It is indicated for administration into the surgical site for post-surgical analgesia, requires no catheter or additional device, supplied in a ready-to-use aqueous suspension, or the volume can be expanded to accommodate larger surgical sites, and it's administered using a single-dose deep tissue infiltration technique. Some other safety information. Exparel is contraindicated in obstetrical paracervical block anesthesia. It is not recommended for patients under the age of 18 years old. Non-bupivacaine-based local anesthetics, including lidocaine, may cause an immediate release of bupivacaine from the Exparel if administered together locally. The administration of Exparel may follow the administration of lidocaine only after a delay of 20 minutes or more. Other formulations of the bupivacaine should not be administered within 96 hours following the administration of Exparel. The monitoring for cardiovascular neurological status as well as vital signs should be performed during and after the injection of the Exparel, as with other local anesthetic products. Because amide-type local anesthetics such as bupivacaine are metabolized by the liver, Exparel should be used cautiously in these patients with hepatic disease. Patients with severe hepatic disease, because of their inability to metabolize local anesthetics normally, are at a greater risk of developing toxic plasma concentrations. And in clinical trials, again, most commonly the adverse effects greater than 10% following Exparel administration were the nausea, vomiting, and constipation. I wanted to touch base specifically what I'm most familiar with is the total knee replacement infiltration review. Yeah, so as I alluded to earlier, again, it requires meticulous technique. We talked a little bit about the Exparel being 20 cc's, and what we do is we divide that into a 10 cc of Exparel with 50 cc's of saline and a 60 cc syringe times 2, meaning we have two 60 cc syringes, and we do utilize our first injection of, or I should say infiltration of the Exparel following all of the cuts and balancing. And you can see kind of on the left slide, this is kind of our guide. We inject in a lot of, after the cuts and balancing, we'll do a lot of the subcu tissues, the suprapatellar patch, the ligamentous structures, in particular, where we see a lot of patients experiencing a lot of the pain is the posterior capsule. And this is one area that the surgeons that we're working with will be injecting into that area, because we do want to make sure that we're avoiding the vascular branches there. So the PAs kind of inject a lot of the ligamentous and soft tissue structures. Our physicians in particular do the posterior capsules. And after the trials are set in place, the implants are put in, and you can see on the right-hand side, then we use the second 60 cc syringe, and we inject a lot of the subcu tissue and a lot of the periosteum of the femur, patella, and tibia. And basically, we also do a lot of bilateral total knee replacements, and we are only allowed to use 20 cc of the Exparel, so we do expand it in a similar situation. Although we do see a lot of the patients having a single total knee replacement, their pain relief for multiple reasons is obviously much better than those having bilateral knee insole on the body. At this point, I want to kind of open it up to questions, and I wanted to kind of get an idea who is presently using the Exparel, what results have you seen, what roadblocks may your institution have with obtaining the Exparel on formulary, and maybe talk a little bit about your experiences, and I can kind of talk a little bit about how we championed to get this medication on board when we made the transition from the University of Penn to our present institution. We had to, myself included, we had to come up with a spreadsheet and kind of do a cost analysis breakdown, why we want to put this on formulary. What the goal was, obviously, pain relief in a multimodal fashion to help, the patient. And, we could talk a little bit about all of that. And again, barriers that your institution may have obtaining it. I can, allude to some of the things that we've done, pushing the medication through pharmacy and therapeutics committees and so forth.
Okay, John, great. Quick question for you. Any contradictions with Surgiflow? No contraindications. Oh, okay, great. That's the only question we've had so far. Attendees, you can still submit questions by using the questions feature located on the right-hand side of your screen in the dashboard. Okay, John, we've got another question for you.
Okay.
How did you prepare the OR staff to ensure consistency for each patient?
So what we did is Pacira Pharmaceuticals, they have, Amisha, maybe you can help me out with this. They have, I guess, clinical educators that are basically nurses that took the time to come out to our facility to review the following, spend time with us. They almost spent maybe a week or two in the OR with us, educating the OR staff, the techs, the PAs, the surgeons on proper infiltration techniques, storage, and all of the following. And they kind of got us going. And, we played around with it prior, but until we had that proper and formal education, that's kind of was the deal breaker for us.
Excellent. Okay, here's another question for you. When you first start out, how much volume should you use, especially with larger patients?
So you can expand it out to 280 cc's, not to include the Exparel, so it's a total of 300. So again, that's a great question. A lot of the larger patients, it's a bigger surgical incision, it's a larger surface area to cover. So I always like to say anywhere from 120 to 140 cc's would be a good start, and you can kind of titrate that accordingly depending on your results. But you can never go wrong with a greater expansion because the goal is to kind of push these liposomes across a larger surface area because they're not going to travel well. Again, it's encapsulated by lipid molecules. So they kind of remain in that lipid molecule until they kind of just degrade naturally, and that's when the medication's released. I could tell you when we first started, and this is a mistake that we made, we were using larger bore needles, such as 18, 19 gauge needles, and we weren't utilizing the proper expansion techniques. And what was happening is we would infiltrate in certain areas, and then you see the medication kind of, come right back out through the needle that we were injecting, basically. So we'd inject with this 18, 19 gauge needle, and you see the medication kind of retract itself. And we weren't expanding well enough until basically, the clinical team came in and kind of instructed us on the following, and it just makes sense to inject in multiple locations and expand the volume, and I think that will be a good start. Approximately 120 to 140 cc's would be a good baseline and titrate it from there.
Excellent. Okay, we just had a clinical comment that was submitted. They said we use this in a multi-specialty ASC for total knee, hip, and shoulder, as well as TLIF and general surgery procedures. We added the drug in 2012 and have seen patient satisfaction with pain management, including increased mobility earlier in the recovery process.
Yes. So was there a question there, or is that, it sounds like a positive result?
No, sorry, it was just a comment to further what
that's a good comment. And again, when we came here to this new facility, we've combined the Exparel with a variety of different multimodal pain medication approaches, trying to take away from the utilization of narcotics. We've changed protocols allowing our patients to get up sooner. In fact, our patients are walking post-operative day 0. And for those of you in the audience who may work at an ambulatory care center, Exparel, I think, is the key for those for patients who are being discharged, in a 23-hour realm, or maybe going home from that, going home after the surgical procedure, post-operative day 1, or going to a rehab facility. It's all about getting the patient up, moving earlier, which our studies have shown that Exparel allows our patients to walk further. Exparel also proves decreased adverse effects that we see with the narcotics. We used to see a lot of delirium, postoperative iliuses, nausea, vomiting, and that's kind of fallen away at the wayside for the most part, and it's all beneficial. You know, it's all basically for the patients who have had a total knee with us, 10 years ago, and now coming back for their contralateral knee. It's night and day, and it's amazing to see just the progress that we've made.
Excellent. Okay, so just to clarify, we did have someone ask a question: do the patients still need narcotic pain meds post-op?
Yes, we do provide our patients. So preoperatively, I'll give you what we do. So for our total knee and total hip patients, preoperatively, we give a dose of Firmev, and that is IV acetaminophen. We give a dose of Neurontin, a dose of Celebrex, and one dose of OxyContin. Postoperatively, we put the patients, obviously all of our patients in particular are getting the Exparel. We do provide the patients with Firmev, the IV acetaminophen, for 3 doses for a total of 24 hours postoperatively. We also continue the Celebrex, and we put the patients on Oxy-IR 5 and 10 milligrams. And for the first 24 hours, we will give Toradol, and we will give IV morphine or Dilaudid for breakthrough. But that basically falls off after 24 hours. So our patients aren't narcotic-free. It's just a significant decrease with the narcotic usage. And, total knee and total hip replacement is a big insult on the body. There's, no lying about it. The patients are going to be in pain. We've just found a way to limit it significantly.
Excellent. Here's another question for you, John. When you are first starting off, what volume should you use for TKA?
I would say 120 cc's, 120 to 140 cc's, and ideally I would divide that into 2 separate vials. And like I said, when we do, after we do the cuts and balancing, we'll inject it in the soft tissues. We'll use that 60 cc syringe, and that 60 cc syringe does have 10 cc's of the Exparel in it. And following the implementation of the implants, we do it in the periosteum regions in the femur, patella, and tibia. Again, we didn't start off doing that. We were basically using 160 cc syringe, but we found out expanding the volume. And it was a little bit of trial and error, but we did find out, through our research, through talking with Pacira, medical affairs and representatives, expanding the volume was the key, and rightfully so. We've seen positive results with that.
Excellent. Another question came in for you. Is there a time frame for onset of pain relief with Exparel?
The onset is fairly immediate. You'll have an immediate release of the liposomal bupivacaine, and that's usually about the first 2 hours. But I'd say the key is basically 12 to 48 hours is when the patients are going to experience the most pain relief. The first 24 hours, patients do excellent, but 12 to 24 hours, I don't know if you recall from the slide prior, that's when you'll see the greatest increase in the plasma concentrations of the bupivacaine, and it does last for approximately 96 hours. We also do provide the patients with a little bit of Marcaine that is injected into the soft tissue area prior to implementing the Exparel, and what that Marcaine does, we have to limit it, but we basically give 25 cc's of a 0.25% Marcaine, and that is basically a 2 to 7 minute onset of action, and that will last approximately 8 to 10 hours, and at that point the Exparel is taking effect. So our patients do very well at the 48-hour mark, and by day 3, a lot of the pain is kind of passing at that point. So their narcotics are being limited at that point as well.
Excellent. Okay, another question for you. When you're first starting off, what are some pointers that the OR staff should be aware of?
I think I could defer that to Amisha. I think the key is just reaching out to a local representative and having the proper team in place. Again, when we started off, we we wanted to just trial it without, being educated properly and so forth. And the resources are available. Like I said, the team spent maybe 2 weeks with us in the operating room to provide us with all of the education that we needed to succeed. I really don't know how to answer that question appropriately other than I think just reaching out to the proper resource prior to initiating.
Excellent. Okay, another question for you. What about hip patients? I hear that hip patients don't hurt, but I think that they do hurt, but maybe not as much as knees. Is there a value to adding this for hip patients?
Yeah, definitely hip surgery is painful for sure. I do believe, and studies have proven that knee surgery is more complicated. It does exude more pain on the patient. Hip patients do very well. I do agree with that. We do provide Exparel to the patients regarding our regarding total hip replacements. I think there's a huge benefit. We have a pretty famous hip surgeon that has joined our practice. He was with us at Pennsylvania Hospital, and then we made the transition here. We began using the Exparel. Patients are walking for the post-operative day 0. A lot of our hip patients are going home post-operative day 1. Most probably are going home post-operative day 2, but it's been a significant decrease in our length of stay, specifically for our hip patients that used to have a length of stay of about 3 to 4 days. This was 3 years ago, and now I'd say our length of stay is maybe about 2.2 days from the last statistic that I looked at. So I think the length of stay is affected. I think the patients are ambulating much sooner with decreased pain too. But I do agree the hip patients do better from a pain management standpoint than the knee.
Very good. Okay, another question came in. Can Exparel be used in conjunction with a nerve block?
Yeah, that's a great question, and a lot of orthopedic services are doing, basically they're doing general anesthesia and they're doing a femoral nerve block with the injection of the Exparel. And the good thing is with femoral nerve blocks, they're doing adductor canal nerve blocks. I apologize. The benefit of the adductor canal nerve block is it doesn't have as much effect on the quadriceps muscle. So the patients are able to ambulate a little bit better than if they had a femoral nerve block. When we first came to our facility, we were going to do the Exparel with the adductor canal nerve block. However, we just experienced phenomenal results with the Exparel, so we decided we didn't need to take that other approach. But I can tell you that there are a lot of facilities doing both the adductor canal nerve block and the Exparel. For us, we're doing spinal anesthesia, and we're doing Exparel infiltration.
Thank you, John. I just wanted to make a quick clarification on that comment. Exparel is not indicated for a nerve block, but people do use a nerve block separately and then also infiltrate Exparel into the surgical site. Other people use it in combination, but that is considered off-label. We are not promoting that today, but we just wanted to clarify that.
Thank you.
Very good. Well, thank you so much for your time, for your information that you've shared with us. Again, OR Today would like to thank our sponsor, Pacira Pharmaceuticals. I'd like to have all of the attendees visit them at www.pacira.com to learn more. Attendees also remember to obtain your certificate of attendance. You must complete the post-webinar survey, which will appear immediately on your computer screen in just a few moments. Certificates will be emailed on or before June 11th. If you do not receive the survey, please email us at webinar@mdpublishing.com. Please visit ortoday.com/webinars to register for our next OR Today webinar, which will be on June 18th, featuring Carol Stamets as she presents Mind the Gap, Raising the Bar with Patient-Focused Warming Strategies. Thank you all and have a wonderful afternoon.
Thanks.